Based on your education, training, experience, are there recognized, known, and accepted complications for carotid endarterectomy surgeries?
There are.
Is transection of the hypoglossal nerve, when it's located in an unusual and unexpected location, one of those complications?
Yes.
And it's a recognized, known, and accepted complication for the surgery?
That is correct.
What are some other...
Well, you never want to say accepted. You hate to accept a complication, but it's certainly recognized and known. We try not to have any complications.
But in terms of surgery, it's accepted that it does happen.
Yes.
And it's accepted that it does happen despite or in the absence of negligence, correct?
Yes.
What are some other complications that can come out of carotid endarterectomy?
Well, the one we always worry about, is what you're going in to prevent. Approximately, in people that do a lot of carotid endarterectomies, you have a 1 to 2% risk of having an intraoperative or perioperative stroke. So, that's always, that's what you're going to prevent, yet 1 to 2% of you will have a stroke. And so that's the big one that we're always worried about. Then you have the bleeding, infection, cranial nerve injuries, heart attack, death. But fortunately, that's very rare in this operation. But
I'm sorry, go ahead.
Good.
What are the most common cranial nerve injuries for this type of surgery?
The three big ones are the hypoglossal, the vagal or vagal branch, and there's a nerve, the mandibular branch of the facial. The facial nerve comes out back here near your parotid gland, which is right in there. And there's one of the branch that supplies the muscles around the mouth. It's usually just a traction injury. It usually gets better, but that's one of the most common ones. But it's a toss-up. You will read various articles or reviews that the hypoglossal and vagal branches are pretty even.
And what are some of the ways that cranial nerves are injured during carotid endarterectomy?
Well, you can probably one of the most common ways are by traction. The vagus nerve is it's always right there in the carotid sheath down low. I mean, you're always going to be in the area of the vagus nerve. Hypoglossal nerve, not so much. If it's up high and you have a low lesion, you're not likely to be near the hypoglossal nerve. But just sometimes the vagus nerve will be right on top of the carotid artery. And most of the time, you think of being behind it, but sometimes it'll be draped right over the top of it, and you have to manipulate. We try to touch the nerves as little as possible, but you try to tease it off the vessel so you can get it out of the way, so you can work on the artery. So just traction on the vessel. We use an electrocautery. It's possible to get a heat transfer to the nerve and cause a problem, or you can cut it.
In your 30-plus years of experience of doing these surgeries, have you ever found the need to actually, with your fingers, with the gloves on, touch the hypoglossal or vagus nerve and push it out of the way?
I try not to touch the nerve. I try to get the tissue around the nerve, and I don't use my fingers. My big old finger, you're down a little tiny hole. I wouldn't be able to pick it up anyway. But you try to tease it away from the carotid artery by getting the tissue, the perineural tissue, and moving it out of the way.
And in your experience, have you ever touched the hypoglossal nerve and rubbed on it so you could feel the texture?
I try not to touch it.
What is the incidence of cranial nerve injury during carotid endarterectomies?
There again, you can. What I carry around is there's probably a 5 to 15% chance of having a symptomatic cranial nerve injury. Now there are some studies that you can injure one of the nerves to the vocal cords, and you can have enough compensation from the vocal cord from the other side that you may not notice, and people may not notice much change in your voice. Now, you may have a profound change and aspirate and whatever. There's a number of times people don't have any change. But if there are some studies that have looked at where they take a scope and look down your throat or through your nose and look down your throat to see if those vocal cords work. And the other thing, you can look to see how the back, what we call the pharynx, how the back of the mouth moves and everything. If you do tests like that, the actual incidence is probably up as high as 25%. And you got other papers that say it's even higher than that. But I sort of carry around the 5 to 10 to 15% risk of cranial nerve injury.
And does the literature separate out those kinds of injuries from transection injuries alone, or are they generally looped in together in the literature?
They're generally looped in together.
The functional recovery for nerve injuries, is it slow or fast?
Very slow. I had one patient that had one of the vagus nerves that was right over the bifurcation. He had 99% blocks on both sides. And we moved it, and before we did the other side, we looked down his throat, and that cord was paralyzed. So we knew he hadn't cut it, so we waited 6 or 8 months, and it finally came back. But they talk about the nerve regeneration is about 1 millimeter a day, and it can take a long time.